Hundreds of members of village health teams like Immaculate Alupo and John Robert Opedun in Kumi district, previously working in HIV management and prevention, supported through various USAID initiatives, have been rendered redundant.
Partner with the Teso under TEP, triple elimination, where we were given a task to test mothers who come for YCC.
Been getting some help from donors, but right now we are serving freely. For sure, it is very hard because we are the ones attached health centers once in the villages.
According to the Health Ministry and several reports, VHTs on various USAID-funded health programs were trained, equipped, and facilitated to work across villages all over the country.
We are not facilitated. There is nothing like motivation. So we are just giving our time.
Of work are there, but so far we cannot do it because we also have families. We are just once in a while like that because we are not used to our villages. But really the life is hard.
USAID was a key financier of activities of the AIDS Support Organization, or Teso, to a tune of $17 million or 63 billion shillings. However, all that came to a screeching halt on January 20th, 2025, when US President Donald Trump returned to the White House.
It'll be quite an important signing, so we thought we'd let you watch.
He started off by signing a flurry of executive orders, including one pausing foreign aid programs for 90 days pending a review. He also announced Washington's divorce from the World Health Organization. USAID disbursed the highest amount of 652 billion shillings to the health sector through 27 projects, including HIV/AIDS care, tuberculosis research, and malaria prevention, which were disrupted. Dr. Emmanuel Ongala, the district health officer for Kumi, acknowledges the widespread impact of the cessation of USAID funding.
Because the partners who were getting money directly to support us had to lay down most of the activities, including closing the district offices, and therefore meant that the work was now left to the district to try and use the available resources from government to try and implement these activities. Activities like outreach to HIV clients, taking for their medication, monitoring their response to treatment have actually been hindered.
Not just key health programs, but also human resource, laboratory research, and community outreach initiatives. Dr. Jane Ruth Acheng, the former Minister of Health, said the government responded promptly, but admitted that development aid financing for health has shifted markedly.
Whereas this has been felt initially when we had specifically the US government come in with the executive orders, our government came in to bridge the gap. And the Ministry of Health received over 440 billion shillings to address that gap. So that is why you never saw any stockouts of antiretroviral drugs or anti-malarial drugs or test kits. That was addressed.
And most of us had actually hoped that after COVID-19, given all the vaccine apartheid, as people referred to it, where African countries were put at the end of the queue, then maybe something would happen where health would get prioritized. But then after COVID-19, we went back to the normal, So with Trump coming in, I think it made this whole investing in health priority set by the African Union, made it more of an urgent issue.
Africa's health sector, according to an April 2025 report by the African Centers for Disease Control, or CDC, saw a sharp decline of 70% in development assistance from 2021 to 2025, compounding deep-rooted structural vulnerabilities.
Those of us in the health space at a global level already recognized that overseas development assistance for health was dropping. It only, it sort of ticked up during COVID-19 because of COVID pandemic, but the trend had always been going down.
Some critics have variously argued that the closure of USAID and the realignment of development assistance for health is the much-needed shock therapy for poor countries to start rethinking their priorities and financing much of their development needs through rallying private sector capital, regional collaborations, public-private partnerships or PPPs, among other innovative ways. Dr. Deus Bazira, the director of the Global Health Institute, a health think tank in Georgetown University, told NTV that discussions on African health sovereignty have been long overdue.
So in August last year, President John Mahama of Ghana hosted a summit in Accra on health sovereignty and invited different countries, but also global communities to talk about how to reform or reimagine the global development architecture using health as an entry point, because health also happens to be the one that has attracted the most development assistance over time.
From the 2001 Abuja Declaration, which required African countries to allocate at least 15% of their national budgets each year to improving their healthcare systems, to the 2023 Lusaka Agenda, a Pan-African framework to reduce reliance on external donors, Dr. Bazira says governments kept paying lip service to the issue.
Access to healthcare for all populations. This has nothing to do with money. Money is part of it, but it's not everything. That's even why in countries like Uganda still, even with limited health budgets, and this is common across Africa, rarely do health ministries spend all the allocated money to them in a fiscal year. So it's not just about the money. And so that's why we framed it as health sovereignty, which starts first of all with sort of a mental shift in countries, for countries to believe that they are the ones responsible for determining their own destiny when it comes to the health of their populations.
To the relief of many poor countries, in the place of USAID, the Trump administration introduced bilateral health cooperation agreements under the America First Global Health Strategy with certain conditions, including specimen and data sharing. However, some countries like Ghana, Zimbabwe, and Zambia have rejected the deals over national sovereignty and sensitive data sharing requirements.
But then again, on the flip side of it, the US government has signed a memorandum of understanding with the government of Uganda that will see us have about 2.3 trillion Uganda shillings, out of which 500 million US dollars is government of Uganda money, and the other 1.7 trillion shillings is US government money that will come in every year for 5 years. So it is a co-financing. And the beauty of it is that this money will be going on the budget of government of Uganda to ease planning and also to help us identify critical areas that needs to be addressed.
So obviously, if somebody's giving you their money, you should expect that they're going to get something in return, okay? And secondly, these MOUs were supposed to be negotiated. And I am privy to some countries that really negotiated seriously and they got a good deal. But there are also some countries that, for reasons I've explained before, where their sovereignty was lost for a very long time, didn't think they could even negotiate.
Currently, a group of African countries have rallied behind a new initiative dubbed the Africa Reset, spearheaded by Ghanaian President John Mahama, with the aim of African countries self-sustaining healthcare financing. A follow-up meeting was convened in Kampala in late March, attended by representatives from Tanzania, Eswatini, Senegal, Zambia, Botswana, Uganda, Kenya, and Tanzania. However, with the assured 6.3 trillion shillings under the US Memorandum of Understanding over the next 5 years, it remains to be seen whether the government won't fold its arms again.